Thank you, everybody, for coming. Talk a little bit about cognitive behavioral and existential therapy for chronic pain. Cognitive behavioral therapy obviously has been around for a long time, so is existential therapy. Cognitive behavioral therapy is pretty common in a lot of conditions. We use it for chronic pain specifically because there's a lot of evidence out there that it works. The existential portion isn't something that's typically tied in with chronic pain, but it's something that in my practice I use pretty extensively because I find that cognitive behavioral therapy does an excellent job of addressing symptom management. I think the existential portion comes in when you're dealing with life changes for people. Dealing with chronic pain creates a lot of conditions, a lot of life changes for people. They have to kind of redefine who they are and how they approach the world. So, I'll talk a little bit about all of this. Just to give you a quick overview, some of the things I'll be covering again, short period of time. So, essentially I'm packing in a lot of information into about 40-45 minutes. So I'll give an overview of chronic pain because it does differ from acute pain. Okay, there's a difference between a broken foot versus someone who's got a condition that lasts long term. I'll talk about the multidisciplinary model. I work with, as a psychologist, I work with occupational therapists, physical therapists, vocational counselors, physicians, nurses, biofeedback, all of that. This all goes into a multidisciplinary model for chronic pain. And then I'll talk about more specifics with cognitive behavioral therapy, which is going to be kind of the bulk of things, and then some existential aspects, and then have some time for some questions, and that should cover it. Again, if you want to email me, or I'll give that information at the end, because like I said, there's a lot of information, probably going to want more. You can always contact me, not a problem. So, what is chronic pain? The definition is kind of arbitrary. There's many definitions out there. I'm not going to throw a bunch of stats. Pain that persists more than 6 months is typically what we define as chronic pain. Again, an arbitrary definition. A definition that I like much more is pain that extends beyond the expected period of healing. So if you have someone who, let's say, has an injury, a lot of the population that I work with has work-related injuries. So they can be on the job, they can hurt their back. They'll go in and get surgery, or they'll go in for physical therapy, they'll go in for different types of physical treatment, but it doesn't get any better. It persists after surgery. So kind of the difference between acute and chronic pain. When we think of acute pain, you think of a one-to-one relationship. There's a specificity theory that exists. It talks about how if you, let's say, break your foot, it hurts. It heals, the pain goes away. What we know with chronic pain is that after healing takes place, it doesn't necessarily disappear. People are still in pain. Why that is somewhat of a mystery still, but as we become more defined and redefined in the medical field, as well as the psychological components that go with it, we're starting to understand how it works a lot more. The psychological aspect plays a huge part in the persistence of pain. Chronic pain spans across multiple conditions and medical disorders, so everything from diabetes, cancer, injuries, and like I said, the work-related injuries are a lot of what we typically see. People who are doing a lot of construction jobs, manual labor jobs, they'll get hurt. They'll go in and see their physician. The physician will give them medications for pain in the short term. And I'll talk about opiates a little bit too, because they tend to work really well early on. Problem is, people develop dependence, tolerance to them, and they don't tend to work in the long term. And then if people do discontinue medications, they tend to have a hyperreaction to pain. Other conditions, like I said, diabetes, cancer, you name it. Depression and anxiety tend to coexist with chronic pain. All right. So I'll talk a little bit about how those things kind of keep the cycle of pain going, because people that have depression and anxiety typically experience higher levels of pain, and pain also tends to lead to higher levels of anxiety and depression for multiple reasons. So, multidisciplinary management of chronic pain. The physician helps with medications, the physical aspects. A lot of times what we do is we'd like to do what's called opioid elimination. So when people come into a comprehensive pain management program, part of that is to eliminate opiates. A lot of them are on high doses of opiates, and we try to taper them off slowly through various methods because they typically don't necessarily work in the long term, and there's better ways to manage chronic pain through other methods like physical therapy, occupational therapy, Work conditioning can be extremely helpful. Vocational counseling, which helps some of these workers get back to work, but also some of them have to go into things like retraining because the job that they did before they can no longer do. All right, if they have a serious injury, especially a lot of times shoulder, back, those types of things, they can't go back to do the construction or the heavy manual labor that they were doing. So they need to get some vocational counseling. A lot of the anxiety that stems from their condition is a result of what am I going to do next, and that's where the existential stuff comes in. Biofeedback is extremely helpful. A lot of people, when they get stressed out, we tense up. Okay, our muscles tense up, and most people have a tendency to get really tense around their site of injury. So if they have a lower back injury, when they get stressed out or anxious, that's usually where they're tense. Now, muscle tension pushes on the nerves, which causes more pain. So through biofeedback, they can get information on a screen that tells them how tense they are, and through various relaxation techniques and even simple postural movements, they can learn to adjust their pain levels and manage their pain and ultimately decrease their pain. Pain management is management. It's not getting rid of the pain. The pain, in most cases, is always going to be there. It's just a matter of how they're experiencing it and to what extent. Some other aspects of things like physical therapy and occupational therapy. Physical therapy works on not just stretching muscles, but also cardiovascular fitness. Do a lot of treadmill stuff, outdoor walks, things like that. Stretching is a huge, huge, huge pain relieving method. Most people don't realize this until they go in. What happens is they get hurt, they're laid up for a while, they're inactive, everything kind of tenses up, slows down. So we want to get them back into moving, but it's not just stretching, it's also other aspects of fitness, cardiovascular fitness being one of those, strength training being another, so weightlifting, things like that. Occupational therapy is more work conditioning, so it's getting people back into the workforce, but it can also be just daily activities. Some individuals with chronic pain have a hard time doing things like dishes, laundry, household tasks. And so there's various methods where through pacing certain activity levels and through gradual retraining and strengthening, they can get back. So as you can see, there's a lot of physical stuff, but the psychological component to all of this is extremely important because our perceptions are what manage and continue to keep the pain going. Beverly Thorne came out and adapted cognitive behavioral therapy to chronic pain specifically. If you look her up, there's a book that she has that goes through different modules, and we use 10 different modules that she has outlined in her book. The first module looks at the pain and stress connection. Okay. Stressors tend to increase pain. Pain itself is a stressor. So there's kind of a vicious cycle you can see there. If there's increased levels of pain, you're going to have increased levels of stress, which leads to more pain, which leads to more stress. And that's the cycle that we get in and try to break. All right. How we appraise situations plays a big role. A lot of the people who have pain, when they're going to do certain activities, anticipate there being an increase in pain, and you get what you expect. So if you're going to do certain activities and you're anticipating increased levels of pain, you're going to have increased levels of pain. So we work a lot on fear avoidance because many individuals don't want to do certain activities because they think if I do this, I'm going to hurt myself more or I'm going to have more pain. And a lot of the educational components that we do, we address this fear avoidance because when you don't want to do something because you feel like you're going to hurt, there's a difference between hurt and harm. Just because you're doing something and your pain levels go up doesn't mean that you're causing more harm or causing more damage to your injury. The typical cognitive behavioral stuff, identifying, challenging, and modifying negative automatic thoughts, intermediate beliefs, and core beliefs. So I'll talk a little bit about some of the cognitive behavioral aspects. Automatic thoughts are these kind of snapshot judgments that we make about situations that we get in. All right, the brain is a very efficient processing machine, but sometimes it gets hung up on certain things. So when we get into certain situations, we have certain expectations. So going into, let's say, a certain job and a certain activity, if you know in the past that you've had pain when you did that, and you're going to have to do this activity again, your expectation is increased, thus creating more pain. So we help people to restructure some of their beliefs about certain activities, certain situations that they're in. And a lot of this is first identifying how they appraise stressful situations. So if we look at a situation as a threat then we typically experience more stress, more anxiety. If we look at situations as a loss, we typically feel depressed or stuck. But if we can help them transfer their thoughts from looking at a situation as a threat or a loss and turning that into a challenge, then it's no longer a stressor. Because if a situation becomes a challenge, it's something that we can cope with, it's something that we can overcome. Therefore, it's no longer a stressor. And so we go through the first module is on pain and stress, just explaining how stress and pain kind of keep each other going. Modules 2 through 6, we break down the whole cognitive behavioral strategy, talking about automatic thoughts, transitioning into intermediate beliefs, which are the shoulds and oughts and I guess assumptions that we have about ourselves, the world, and other people. So a lot of people will have difficulties with interpersonal relationships, which can create stress, which can create more pain. We also have a family support group that we use to help people to use assertive communication, which is another module that we teach. And through techniques of having more assertive communication, people can typically communicate the fact that they're not able to do everything that they used to do. You can't see chronic pain. It's just like diabetes, a lot of forms of cancer, you can't see those things. You don't know people have it. So some individuals will go into a situation and their family members or friends expect them to be able to do things like they used to or as expected, and it's not always the case. You can't see the pain. So for some individuals, you know, picking up a box that's 10, 15 pounds, you just don't even think about it. We just do it. But for individuals with injuries or chronic pain, they can't. But other people expect them to be able to do that because they've always done that, which creates a lot of tension and friction between people, interpersonal relationships. We also implement positive coping statements and relaxation practice in one of the modules, and what this is helping people to come up with positive statements that they can reinforce to themselves. A lot of times there's awfulizing and catastrophizing, things that keep them from getting through their day. They can wake up and they'll be in pain, and so it starts off the day with, this is going to be a terrible day, and they keep reinforcing that message to themselves, which keeps the pain going. What we try to do is get in there and get more positive strategies. I can cope with my pain. It's not going to be this way forever. I'm going to get some management over my pain. Just ways that they can implement more positive self-talk. Relaxation practice, we use many different tools for relaxation. There's applied relaxation, which is some of the things you're probably familiar with, which is a progressive muscle relaxation. So they'll go through and tense up different parts of the body and then relax them. What this does is it allows them to get a sense of control over their own body, but also the tension that they have in their muscles. There's other simple relaxation practice which they can do. You can do just simply sitting in your chair. So deep breathing, diaphragmatic breathing. A lot of these things we don't think about. If you actually pay attention to your breathing at times, you'll realize that you're taking short, shallow breaths. All right? Not a lot of us stop and actually take these very deep breaths, and when we do, we tend to relax. When we're focused on our breathing, we're in the present moment. We're not stuck in what's happened. We're not looking to the future. We're focused on our breath and where we're at in the moment. We also use expressive writing. This is just a way for individuals to maybe get some of the thoughts out that they're not aware of. A lot of the cognitive behavioral stuff that comes up when we use sheets and have them document some of their patterns of thinking, people aren't necessarily always aware of. We have thoughts that are going through our minds all the time, and we're not always aware of them. Getting them out on paper helps a lot. It helps them to communicate better with people around them. It helps them to communicate better with professionals that they're working with. A lot of these individuals have gone to various professionals, doctors, physicians, and they haven't been able to manage their pain, and they're very frustrated. What that does is that actually leads to an increased level of pain because they're frustrated. Frustration, irritation, depression, anger, these are all these negative emotions that we experience from time to time. A lot of individuals tend to hold on to these things because they're in pain and they're stuck. It's kind of the learned helplessness model that goes along with this. If you can't change something because it's your body, what do you do with it? Well, you're stuck with it. Well, how do you change that? The last session that we do is kind of a review of all of these different modules, and it kind of helps to wrap everything up, put it all together, and using challenging thoughts, challenging beliefs, getting down to some core beliefs that these individuals have. their lives tend to change after an injury or getting a diagnosis of things like fibromyalgia or any chronic pain condition. You can't do things the same way that you used to, but it doesn't mean that you can't do things. And that's where we try to get people over that hump, so that they can continue to live their life even though there's pain. So again, pain management versus getting rid of the pain completely. CBT and chronic pain. Other things that we address are things like anger management. It makes a lot of sense. If you're in pain all the time, people tend not to be too happy. And anger perpetuates more pain. When you're irritated and frustrated, focused on your pain, it's really hard to do anything else. We cover grief and depression, and in this we discuss symptoms of depression. A lot of individuals after a life-changing event or getting a diagnosis of some sort of chronic pain condition experience depression. And a lot of them aren't aware of it. So a lot of the treatment that goes along with pain management, we might also add some antidepressant medications if necessary. There are certain medications that help not only with depression but also help with pain. So things like Cymbalta, Effexor, they're selective serotonin and norepinephrine reuptake inhibitors. So they don't only work on serotonin, which is the mood-based chemical. It also helps with norepinephrine, which can give individuals who have fatigue and have pain a little more energy, but it can also help to decrease pain to some extent. Not everybody has an excellent response to these medications. Some people have adverse reactions, so part of what I do is monitor those medications because the physician doesn't see them as much as I do. And they're not always reporting to their physician the things that they're reporting to me. Humor and stress management, we know that if you can laugh, you tend to feel better. So we do an entire class on humor and ways of kind of coming up with methods to stay positive, stay happy. Gate control applications. Now this is where we get into specificity theory versus gate control theory. Specificity theory works really well for acute pain. You stub your toe, it hurts. You break your foot, it hurts more. One-to-one relationship between tissue damage and amount of pain experienced. You get the broken bone fixed, pain goes away. With chronic pain, not the case. You fix whatever physical ailment's there, but there's still pain that persists. The specificity theory doesn't apply very well to chronic pain. And so the specificity theory has been around since the time of Descartes, and it's used and still taught in a lot of medical schools. It doesn't apply well to chronic pain because chronic pain is a persistent condition. It's kind of like phantom limb syndrome. Okay? If there was a one-to-one relationship, then how can someone have pain in a limb that does not exist? It doesn't make sense. But there's still nerves there, and again, it goes back to that anticipation piece. When you're expecting certain things, you get certain things, pain being one of them. Gate control is a really nice way. This came out in about the 1960s. A lot of research has been done. Basically what it comes down to is that there are gates in the spinal cord, and we have information coming into our brains as well as information that's sent from our brains out to our body. Now the gates in the spinal cord, when they're open, and things that can open the gates are things like inactivity, pain meds in some conditions when they're taken in heavy doses or for too long of a period of time, when we're feeling sad, angry, upset. These signals are sent from our emotional centers in our brain as well as the cognitive centers, so frontal lobe as well as the limbic system, sending messages into the spinal cord. And as those messages go down, the gates open up. What does that do for pain? It allows more pain signals to get to the brain. One of the misconceptions that a lot of people have coming in is they've had physicians or other people tell them that the pain is all in their head. Partially true, but not so much, okay? Yes, the pain is processed in your brain, but you do have physical pain too. It's just that the brain and our perceptions can alter those signals. We can change the signals, we can stop the signals, or we can open those gates up and let the pain signals get to the brain. Now there's various ways to change the signals. Things like heat, ice, massage. The brain can only interpret so much sensation, all right? It's kind of a limited capacity. So if you have an extreme high amount of pain that you're processing, but then you throw in some sort of other sensation like cold or warmth, your brain has to interpret those signals as well, which means if part of your brain is interpreting those signals, it can interpret all those pain signals. Therefore, the pain signals are lessened to some extent in our brains, perception. Breathe, this is an acronym for biological, relationships, emotions, activities, thinking, and economics. These are different aspects of health. When we typically talk about health, we usually think of things like diet and exercise, all right? Physical components, those are the biological components. We have individuals rate where they fall in these different categories on a scale of 1 to 10, 1 being not so good, 10 being really well. And what we tend to find is that people have very low ratings on the biological components because it's a physical component, and they'll tend to have higher ratings on other areas. But overall health is comprised of not just physical health, but also relationships, emotions, thinking. When we're stressed out and we're thinking negative thoughts, that tends to bring down other areas. Our emotions tend not to do as much as far as activities go. With injured workers, economics tends to be a huge piece because they tend to have about, I'd say, 60% of their income. So they're trying to get better and they're trying to get healthy, but they're not having as much income come in. A lot of them don't know what their next step is, which means what's going to happen. That creates a lot of anxiety. We do a lot of anxiety management where the vocal counselor comes in too and helps out a lot because they don't know what their next step is. If you've got someone who worked construction for 20 or 30 years, hurt their back, can no longer work construction, what do? It's a huge change for a lot of them. A lot of them go into retraining, but the retraining tends to consist of lighter work that they might not be familiar with. Computers, for example, would be one. Pacing is a strategy that we encourage everyone to use, but especially as people are recuperating from an injury or chronic pain. When you have pain all of the time, you can't do things like you used to do. Sometimes you'll have a good day. What people tend to do when they have a good day is they tend to do way too much. And then what happens when they do way too much? They're down for 3 or 4 days after that, which means they're not doing as much. If you can pace your activity level, not only within the activity, but between activities, so maybe do 15 minutes of dishes, maybe go and take a break and then go and do some laundry, switch it up, pace your activity level throughout the day. One gentleman that I worked with, he was progressing in treatment. He decided over the weekend that he was going to get all of his yard work done, so he spent 8 hours on Saturday, 8 hours on Sunday doing yard work. I didn't see him for a couple days after that because he was down for the count. Did too much, didn't pace himself properly. And like I said, this goes for all of us. We tend to not pace ourselves very well, especially when we're feeling good. You want to get in there and do things. We have to remind ourselves to slow down a little bit, break things up, because actually you can get more done in the long term if you pace yourself properly. So what we do with pacing is we have individuals kind of set a baseline for activity. So let's say walking. Maybe they'll walk 3 miles. Their plan is to walk 3 miles a day. So what we do is we have them go out for a week, mark how far they can walk. We get an average, and then we decrease that baseline average by 10 to 20%. And we start them off at that. And then after a week of doing that, if they feel good, bump it up a little bit. Week after that, bump it up. Before you know it, in about 6 months, they're doing more than their target goal. One thing I don't have up here, but is really extremely important, is goal setting too. More in the positive psychology realm of things. But setting goals and breaking them down into smaller goals and then breaking those smaller goals down into simple behaviors can go a long way. Stress in the family, I kind of talked about that a little bit, but injuries and chronic pain don't just affect the individual that is dealing with them. There's a lot of changes that happen to the family as well. These individuals can't do things the way they used to do. They can't do them at the speed they used to do them. They can't do the workload that they used to do, which means that who has to pick up the slack? Family, friends, okay? They have to adjust as well, which means there can be a lot of conflict in that, a lot of expectations that change. It's not just an individual that has to change, it's the entire system that's around them. We also talk about relapse prevention and follow-up. So the way that the pain program that I am part of works is that we do treatment for 4 weeks. So 5 days a week for 6 hours they're in treatment. They come in the morning, they do an hour of physical therapy, an hour of occupational therapy. There's medical education classes, which talks about things like opiates, opiate use, surgeries, the different results that can come of that. There's also nutrition, biofeedback, And so medical education will come in there. We also have psychological education. So not only are we using these procedures with individuals in our office, but we're also teaching them how it works. Part of CBT, psychoeducation. I spend a lot of time drawing neurons and explaining how antidepressants work. Most people think that if they take more medication, they're putting more chemicals in their system. It's not the case with things like the SSRIs. It's actually helping to regulate what's already there. So education is a huge, huge piece to the kind of midday for them. So they'll have after the med ed and psych ed, they'll have a break for lunch. They'll come back in the afternoon. They'll do another hour of physical therapy, and then they'll get education on vocation. So it can be resumes, job searching, things like that. And that's kind of the treatment phase. Once that's done, 20 days, then they go into a week of follow-up, which is half days. They come in the afternoon, they do physical therapy, occupational therapy, and then some sort of education, either through the physicians, nurses, psychologists. And relapse prevention is part of what we do in follow-up, because what we see is that individuals progress really nicely through treatment, and then they're doing okay at follow-up, but what happens after follow-up when they're not in a structured program anymore is that the gains tend to drop. And that's where the problem comes in. That's why we want to try to educate as much as possible so that when they're done, they can continue to do the things that they did when they were in treatment. All right, so some existential aspects. Like I said, I think cognitive behavioral therapy does an excellent job of addressing some of the symptom management, challenging some of the ways that they're thinking, changing their relationship with their pain. But I don't think it covers the fact that a lot of individuals with chronic pain have to make life changes. You go from working a certain job for many years to having to do things differently, or you're diagnosed with a condition that you didn't have before. There's a lot of grieving and loss that goes along with that. Identities change. Go from being a construction worker to having to repair computers. It's a big change for people, especially if they've done it for a long time. So I like to address the fact that, life changes. Who do you want to be now? You were someone before. Who do you want to be right now and going on into the future? Locus of control tends to be a big issue as well. When you go to having kind of things set up around you, you've got your career, you've got your life, and then all of a sudden you get diagnosed with a pain condition or, again, an injury, you lose a little bit of your control. Physical body, we don't always have control over it. Interesting thing is a lot of the sympathetic functions that we have in our nervous system, we do have more control over than we realize, which is why biofeedback is extremely helpful with some of these aspects. Individuals who tend to have an external locus of control tend to see the world around them as responsible for what happens to them, and so they're always looking to things outside of themselves to define how they're dealing with things, who they are. This can be a problem because if you don't have an internal locus of control, you don't feel like you can make changes in your life. And so shifting from this external to internal locus of control can be extremely empowering to individuals, especially with chronic pain. When they learn that they can manage their pain, it's no one else's, and they can regulate it to some extent through changing the way that they think about it, they tend to develop more of an internal locus of control and find more active ways of managing their pain. Active meaning things like stretching, physical activity, walking, distraction. Okay, music is an extremely excellent distraction technique. And I won't go into music too much because it's a passion of mine and I don't want to get too tangential. Responsibility is another big piece. People have been going to appointments and appointments and appointments. They finally find out what's wrong, and then what do you do with it? Individuals get caught up in having other people tell them what's going on and how to manage it. So either getting a prescription for pain medications or being told to go to this appointment or that appointment or various things. And once they get a sense of responsibility, they tend to take a more active role in their own treatment, tend to see them less because they're doing much better in managing their own pain. It can be very isolating when you're in pain. You don't necessarily want to go out into the world and do things because it hurts. And so people tend to stay inside, shut the doors, they don't interact with people, and that tends to lead to things like depression. And so then you're not just treating the physical, you're treating the psychological as well. Meaning, as I said, is a huge piece because things change over time, and you want to help people redefine who they are, where they're going. I think it's more important to look at where they're at in the present moment rather than what's happened. A lot of people get stuck on, well, if I wouldn't have did this and if I wouldn't have did that, then I wouldn't be here in this situation, and that's not helpful. It's getting them more present focused, creating a sense of where they're at today. And anxiety in the future, unknown. A lot of individuals, after doing something, they don't know what's going to happen. And being in the system and managing their pain, they don't feel like they have a lot of control over it. They don't know what the next step is. And that's where, again, education is a huge, huge piece to all of this. I think that for me, I've been trying to blend CBT and existential therapy over the years, and I find that it's a very good way of treating chronic pain because it doesn't just address the symptoms. It also addresses the deeper meaning that's underneath all of it. Also, what does it mean to be in pain? A lot of individuals, you're in pain, you choose to still exist. What do you do with that? And it doesn't, life doesn't stop at that point. So they're choosing to stay alive in the pain. So what does it mean to suffer through the pain? They're doing it for a purpose, they're doing it for a reason. Finding that reason or reasons can be extremely helpful because it sets a focus for them to continue on and do the things that they want to do in life. So as I said, CBT is great for psychoeducation, giving them tools to help manage the pain, changing the way that you think about your pain, changing the way that you relate to other individuals, changing the way that you go through your life. Perceptions about yourself, other people, the world, changing those things, it's great. It helps to give them means to do that. And then I also find, again, that the existential aspects for meaning, identity, and responsibility for self are extremely important because the more responsibility that a person takes for their own treatment, the better they get. They tend not to need more opiates. They tend not to be in the doctor's office all the time. They tend not to require as much help because they're doing these things for themselves. And that's the primary goal in all this. And then to kind of speak a little bit on the opiates, like I said, we try to get people to taper off because when they use higher doses, they become tolerant, and so they need higher doses. I had a gentleman, like I said, who's was on different types of opiates for 10 years. Just kept going, and they just kept throwing prescriptions at him. He kept taking them because that's what he was told to do. And then he discontinued and tapered off. The unfortunate thing is he has what we call hyperalgesia, so his response to pain was increased once he discontinued the opiates because his brain had adapted to having that medication available. When it wasn't, he went into withdrawals. We use Suboxone, which is a great medication to help taper people off of narcotics. But not everybody responds well to that. It all depends on dosages and things like that. But the less opiates, the better. And that's chronic pain and CBT in a nutshell, with a little existentialism thrown in there. So, questions? Yeah.
A lot of the way you described some of the cognitive CBT aspects in caring, a lot seemed to center around mindfulness, but you didn't use that word. Was it just sort of implied there?
Yeah, a lot of the relaxation, the applied relaxation especially, uses mindfulness. When people typically get this misconception that when you're relaxing, you're just kind of relaxing. Mm-hmm. There's actually a lot of activity that goes into relaxing. And so when they're doing applied relaxation, a lot of it is being mindful, being centered where they're at in the moment, focusing on certain aspects of different areas of the body, as well as trying to stay in the present moment, trying to stay positive. Yeah, and I think, CBT today, there's a lot of mindfulness aspects that are just assumed.
Do they accept that readily?
Yeah, some people. It depends too. One of the things we have to keep in mind is, we do initial evaluations to get a sense of where the person's at, and depending on their buy-in to treatment, some people are much more open to it than others. A lot of these individuals that I'm dealing with in chronic pain are coming from working very hard labor jobs, and so these concepts are kind of foreign to them, and it can be a little tricky to get them to quote-unquote buy into it. I think if we can explain it in different ways that connects with them, then they can use it. But we have people that when they go into applied relaxation actually become more agitated. And I think if we look at arousal levels on that inverse U function, where there's optimal arousal levels, certain people respond better, but they're already, jacked up a lot because they're in pain. So it's trying to match where they're at through various means. One of the ideas that I'm toying with is having iPod shuffles with different genres of music, so that when people do go to do relaxation, they can choose what they want to listen to, rather than the soft sounds of a running brook. Because not everybody responds to that. I mean, there's sometimes, some days where they're okay with it, and there's other days where it just irritates and agitates them more. And so doing relaxation isn't always relaxing.
This got me thinking about the community piece of what you're talking about and how relational chronic pain is. Like, my son was colicky for the first year of life, right? And it was tremendously relational in the sense of like, his pain became our pain, right? And then our pain became his pain. How we were doing had a huge impact on how we related to him. And it sounds like your folks get sort of instant community in terms of the treatment that you give, right? They're there, and it's not just intensive treatment, but it's intensive community.
Yes.
Could you speak to that?
Yeah, they come in groups. And so the educational classes are done in a group setting, but then they have individual appointments where we can address specific needs too. And what they do is they tend to find a lot of similarity and common ground in that, which is extremely powerful for a lot of them, because most of them are in their families and they might be the only one that has that experience, and so that system's got its own thing going on. But then when they get into this treatment group, they actually tend to push each other too. And so they tend to progress and get better. What we usually see is, it's interesting, is about halfway through treatment, people's pain levels are up because they're sore. They're doing more activities, but then they're combining together as a group, pushing each other, helping each other through. It can work in the reverse as well, where if you have a few group members that aren't necessarily positive, you can see them starting to pull people down, and so that's where we do more of the individual interventions. But we have a family support group that we do once a month, where people can bring in family members, friends, pets. What we're also starting, we just kind of implemented this, is more of a chronic pain support group. If you do a search, you can find all of these all over online, but there doesn't seem to be a community group, chronic pain support group. And so that's something that I'm going to kind of get up and running, because a lot of people have chronic pain. It's kind of one of those things where you can't see it, so it's like it doesn't exist.
Yeah, and it seems like the misnomer would be that it's a non-relational thing, right? It isolates me from people, it separates me from people, right? But it just seems like community is such a big piece of it.
Yeah, and it has an impact on the family, because that's why we do assertive communication. Individuals who tend to isolate or have more passive forms of communication, that can be just as disrupting as if they're coming in irritable and grumpy all the time. Because someone that comes home, shut the door, they go right to their room, walk right by their family members. The family members are sitting there going, what did we do? And all they have to do is kind of stop and say, you know what, I'm having a bad day, I'm feeling really bad, I'll be out in a little bit. And that's enough to kind of, diffuse the whole, what did we do? But yeah, there's definitely, and families can enable and keep it going too. So one of the paradigms that we operate under is a non-reinforcement paradigm for pain behaviors. So pain behavior is, like individual has a bad shoulder and they're constantly rubbing it. What it's doing is it's reinforcing that they're in pain, and so they're basically keeping their pain going by reinforcing that behavior. And so what we do is we don't acknowledge those behaviors. Whereas sometimes family members will be elicited by that, and they'll go and do more for this person when actually that's not helping. It's keeping the pain going. So there's a huge relational piece to it. It's not just a person in isolation. Even if they isolate themselves, it's still connections with other people.
Yeah, it seems like that shift you're talking about of moving from like threat and loss to challenge in terms of mindset, right? Also this shift in mindset of this is not a you thing, this is a we thing, right? Yep. This is relational whether you want it to be or not.
Yep. Yeah, and that's one of the things that we definitely target, because it impacts the family a lot, just because of activity levels and other things. But if people aren't communicating and they're in pain, it can disrupt schedules. It can disrupt, if there's kids and dad can't pick them up anymore, and they're not explaining why that is, it can cause a lot of issues. And a lot of times with some of the guys that come in that get hurt, that's one of their main issues. I can't play with my kid. I can't play soccer. I used to play soccer with my kid. I can't do that anymore. And it's like, okay, well, let's not focus on so much what you can't do, but what can you do? Can you still go and watch? Can you still participate in some way? And it's changing, you know, that freedom within limitation kind of thing, because yeah, you can't do things the same way, but it doesn't mean that you can't do things. And trying to get people to shift from that, because they do get stuck in, well, I can't do this, therefore I can't do anything. And challenging some of those negative cognitive patterns.
How do you work with somebody who has started stopped wanting to reach out socially because they don't want to explain that they are in pain?
Right. Yeah, some people do get sick of having to explain all the time that, you know, this is why I can't do this and this. So they'll just avoid going out altogether so they don't have to explain that. And what I try to do is try to be really upfront with them, but I try to get them to be upfront with people too. They don't have to explain why they can't do things all the time. They might feel that they have to because that's what's expected of them, but that's what's expected of them from other people. That's their perception of what other people want from them. So getting them to a spot where they're comfortable and secure with where they're at, and then being able to go out and do things and not feeling like they have to constantly explain why they can't do things.
What do you do with people that, because, say, their husband is suffering from chronic pain, then suddenly the wife starts to become full of anxiety, and now she's suffering from pain that isn't being taken care of by the doctor? They're starting to give her injections and pain pills. What do you do with the patient?
Well, and that's where the family support group comes in. Sometimes we'll bring people in with couples too. So it's not just meeting with the individual. If there's outside stuff going on, even though this person's in treatment, that is affecting them, and so we'll bring the couples in. In fact, one of the family support groups that I did, it just one couple showed up, and it turned into more of a couples session than anything, because the husband was injured and had lower back pain, but the wife had fibromyalgia, or that and some other unknown pain condition. And so it was just addressing, one of their biggest issues was communication, because their whole interactions had changed. And so it's dealing with both of them, kind of going back to the community piece, is it's not just one person, you're dealing with the whole system.
I have a chronic pain condition, and one thing you haven't really said is that, like, just for me to say that right now, it takes a tremendous amount, because there is a societal judgment.
Yep.
If they can't see what's wrong with you or whatever, not only does it not exist, but you're a malingerer, or you're,
Right.
you know, trying to get out of things, or you
Or
just...
it's all in your head.
Yeah, you know.
Yeah.
So I'd like you to address that. And also, one of the things I found for myself, and then have since heard from other people with chronic pain, is that using the computer, and when feeling isolated or unable, by communicating with people via, you know, Facebook chat, whatever, is a way that not only does, I think, it have a gateway control thing that actually alleviates pain,
Right.
but it also keeps people connected even when you're limited in some
Yeah.
ways.
Yeah, I went to a conference this past May in Austin that actually talked about e-pain. And so using text messaging via physician or psychologist to patient after they're done with treatment to kind of keep tabs on that, but to keep interactions going. It's part of the reason why we're going to start that chronic pain support group. But yeah, definitely having that connection. As far as going back to the first question you had about, you know, the pain is, you can't see it. Ultimately, you get to a point where you are you and your experience is your experience. No one else can ultimately tap into that completely. And so your experience of things is your experience. Whether they accept it or not, that's up to them, but that doesn't have to impact where you're at.
There's some talk now in medicine about reframing how we look at placebo as something very powerful and intrinsic in human capacity for things like pain. Can you talk about that a little bit?
Yeah, there actually physicians can prescribe placebo caps. Actually, I think they're called C caps, or I'm not sure exactly what they're called, but we see it a lot with antidepressant medication, where people will take like an SSRI and they'll come back a week later and say, I feel great, medication is really working, and that's when we just kind of say, okay, because we know it takes a little bit longer usually for that to work. But anything that works, even if it is, you know, inert and not necessarily impacting them, if it's got that placebo effect, yeah, we're definitely going to, you know, encourage that.
Well, I think too, your discussion about dealing with people's expectations. What do I expect in life, almost philosophically, about the issue of pain? or the specific expectations that you're working on in cognitive restructuring are related somehow to expectations and the powerful effect of, expecting relief.
Right. Yeah.
Like
And-
placebo is, thought to be an active treatment in a
Right,
sense.
right. And I would say that it definitely is. That's why I tend to bring in more of that existential therapy into the chronic pain, because I think it takes, to get at that core, really accessing their philosophical outlook on life in general, and finding out what that is, how much power and control do they have, how much control do we really have? And then addressing the fact that maybe not overall, but today, right now, I've got quite a bit. And getting them to focus more on right here, right now, rather than what's happened or what could be.
Dr. Senske, are you willing to hang out for a minute or two if folks have additional
Yeah,
questions?
I got to fly back to Redmond, but I got to be there by 2, so I got a little bit of time.
Okay, let's say thanks for now. Thank you.
Thank you.